Thank you. Thank you, Alon and Yair, for having me here. We are going to talk a little about of the way that we pathologists evaluate the specimens of TME after neoadjuvant chemoradiation. And I think before I show you that, I wanted to remind all of us that although there's a lot of progress in the biology of tumors, still TME is the TNM is the most important prognostic indicator. The TNM staging, as we know, is a very powerful predictor of prognosis, and it is very useful since the first time that was used in 1948, because we can all talk about the same things using this system. In the US is recommended by the American College of Surgeons and the College of American Pathology. So pretty much you need to use it when you're staging your tumors. Now, we all know that patients that have advanced rectal cancer, most of them will receive neoadjuvant chemoradiation with the idea of reducing local recurrence. It is now proven that good tumor response is associated with better prognosis. And also we know that good tumor response usually means that there's going to be a decreased incidence of lymph node metastasis in the mesorectum. So it does affect the end status. Now, when we give the patient neoadjuvant chemoradiation with advanced rectal cancer, so how does that work? Is it a decrease in T stage, so downstaging of the tumor, or is it that neoadjuvant chemoradiation sterilizes the lymph nodes that were positive before and now they're going to be negative? Is it that neoadjuvant chemoradiation increases the chances of having a negative margin, particularly the circumferential margin of resection? Or is there a value in the decrease of tumor volume, what we would call tumor regression? And I think that probably is a combination of all of these three things together. So I think we can try intellectually to answer the question of which ones of these is more important. First thing, and hopefully I'm not insulting anybody, but I wanted to be sure that we understand the difference between tumor downstaging and tumor regression, because tumor regression and tumor downstaging doesn't mean the same. The only situation in which tumor regression is the same as tumor downstaging is when we have complete pathological response. So a complete pathological response is going to take us to a T0, and that's the only situation in which we can equal tumor downstaging and tumor regression. Other than that, we sometimes can have marked tumor regression, so only a few glands remaining, but without downstaging, and I'll show you an example. Or we can have tumor downstaging, let's say a patient that started with a clinical T3 and now has a pathological T2, but still we have tons of tumor left in the muscularis propria. Here you have an example of a pre-surgery ultrasound. You can see that this is a very nasty tumor going all the way to the mesorectum. We have positive nodes. After neoadjuvant chemoradiation, there was a very nice response with only these areas of tumor left, but they're still in the mesorectum, so this is still a T3. However, the tumor response was almost complete. So what is it going to be more important? The fact that there's almost complete response, or the fact that the patient did not have any downstaging? Maybe both of these, tumor downstaging and tumor regression, predict the outcome in an independent fashion. So I think that there's been many studies that have tried to speculate what is then the validity of the TNM in patients that receive neoadjuvant chemoradiation. Because, we need to think that when you give neoadjuvant chemoradiation, we have a divergence between the clinical and the pathological stage. And then you as surgeons or oncologists, then after you receive the pathology report, need to decide what you're going to do with the patient. So are you going to treat the patient based on the stage that was before the neoadjuvant chemoradiation or after? So in other words, is the YPTN still important to make treatment decisions? there's been many studies that have touched on these subjects, at the beginning with very controversial results, because when you read into the material and methods of these studies, you see that there's tremendous difference in the preoperative clinical stages that were included. The preoperative treatments were very different, some short course radiotherapy, some long course, so you couldn't compare. And very importantly, from the pathology point of view, the way in which the tumor response was assessed. So in terms of the YPT, there's still some controversy, but for sure, we know that the status of the lymph nodes after neoadjuvant chemoradiation still is the most important prognostic factor in these patients with rectal cancer. Now, what happens with the YPT is that most of the times it predicts the lymph node status. This has been shown in several cases, including ourselves. We studied 86 patients with neoadjuvant chemoradiation, and we saw that the positivity of lymph nodes was related to the T stage in the pathological specimen. The thing I wanted to point out here is that even in patients with complete pathological response, we found that 11% have positive nodes. And this kind of gives an alarm as to the fact of, can you always wait and watch these patients that have pathological response, considering that some of them, not a small percentage, may have positive nodes. Our results were the same as these people from Korea, in which they also saw that the rate of lymph node metastasis, even with complete pathological response, was not small. Okay, in terms of the tumor regression with prognosis, is very similar, controversial results with a YPTN for the same reasons. Now, I think that lately, particularly this year, this study over here that is not yet published in the Journal of Surgical Oncology is composed of 581 patients, and they did see that a good pathological response correlates with better prognosis and a decreased incidence of local recurrence. So my point here is that trying to assess the tumor regression is not a minor issue, it's a big issue, and that is where your pathologist is going to come in place to assess that. So evaluating tumor regression is not rocket science. However, the pathologist needs to know how to do it. It starts with a good gross examination and sectioning of the specimens, looking for those histological residual malignant nests, and knowing how to account for the residual tumor, so knowing how to apply the tumor regression grades. So we get the specimens of TME, and after looking at the mesorectum, grading the mesorectum, and inking the circumferential margin of resection, we take, as you've probably heard me say over and over, we take the mesorectum that is not in contact with the tumor, and we put that in alcohol to increase the number of lymph nodes retrieved, and then we open the specimen. You can see that in this case of a patient that received neoadjuvant chemoradiation, the only thing that we have left is this ulcer. So you may think that clinically this is a complete pathological response. When you do your sectioning, see again, there's a little ulcer and fibrosis. It is very important that your pathologist examines all of these sections to be sure if there is or there is not tumor, residual tumor here, because you don't want to call something complete pathological response if it's not. And if you don't examine every single section, that's what's going to happen. You can see here at, when you go closer that it does not appear to be any tumor, just fibrosis and ulcer. Instead, in some other cases, the response is not as good. You can see how the tumor is close, maybe 8 millimeters from the distal margin of resection. And then when you do your sections, the tumor, although the mesorectum is complete, this is an aggressive tumor going all the way to the circumferential margin of resection. Sometimes the response is so good that you as surgeons, when you're trying to touch the tumor, you can't feel it at all. And then it's only when we open the specimen that we see this small area here of indentation. It is very possible that this is a complete pathological response, but until we look under the microscope, we cannot be sure. There are many tumor regression system grades. It doesn't really matter which one you use as far as your pathologist has validated amongst the different team, the different components of the team. The one we use at Cleveland Clinic is the Dworak regression tumor that goes from no regression to complete pathological response. So you have an example here of a case that pretty much have no regression. All of these are islands of malignant glands. Here you have a case in which there is some regression. You see the fibrosis, but the tumor predominates. Here you have more fibrosis than tumor. In this case, you may think that this is complete pathological response, but when you go higher magnification here and you have it on this side, there is some residual tumor left, so this is a near complete response. And this is a case in which after we evaluated the entire area of the scar or ulcer, we did not find any tumor left. The problem, as you can imagine, with a tumor regression grade is the inter and intra-observer variability. So some people have they don't like although they agree that tumor regression may be a surrogate of prognosis, they say that pathologists really are this is too subjective to be used for that. However, this is not the case, and there's more than one study that have shown that the kappa agreement, when you sit down, all the pathologists that are going to grade the tumor regression, and you get to very concrete criteria, this can be done. Obviously, those tumor regression grade systems that have 3-point grades, so minimal, no response, moderate response, and complete response, are always going to be better in terms of intra and intra-observer variability than the ones that have 5-point grades. That makes sense. Now, we were talking about what's more important, tumor regression or the end stage. And we don't know exactly yet. There's only one study that has addressed this issue. And what they found is that tumor regression grade is very important in predicting prognosis if the patients don't have any lymph node metastases. When the patient has lymph node metastases, then the tumor regression grade's importance comes down. So it appears that the lymph node status is more important than tumor regression, but you want to know the tumor regression, especially in those patients that don't have lymph node metastases. As you know, the lymph nodes in the mesorectum are tricky because they tend to be less than in other parts of the colonic tract. They tend to be smaller. And they tend to, it's important that your pathologists know that they're going to be always lower in the lower, the number is going to be decreased in the lower part of the rectum. So we don't have to freak out about that. That's the way that it happens anatomically. On top of that, we know that when you give neoadjuvant chemoradiation, you have a decrease in the number of lymph nodes retrieved. And this has been shown over and over, including our own experience. But what is the importance of that? Does that decreased number of lymph nodes in patients that receive neoadjuvant chemoradiation has an impact in prognosis? Some studies have shown that it doesn't, such as the one coming from Brazil, in which they show that a decreased number of lymph nodes retrieved in these patients did not affect prognosis. Similar, another study coming from France, pretty much showing the same results. Now, our experience is different. We wanted to study this from a little different perspective. We use a group that received chemoradiation and one that did not. And we wanted to see the difference in the number of lymph nodes retrieved comparing two techniques, the classic palpation and visualization and using alcohol. We wanted to also correlate the number of lymph nodes with other parameters that are affected by neoadjuvant chemoradiation, such as tumor size, regression, and the staging. As you can imagine, and as I said before, the number of lymph nodes increased the higher the stage, which makes sense. Also, as we also predicted, the better the response of the tumor, the less number of lymph nodes that we found in the specimen. Now, what was our experience in terms of the importance of this decrease of lymph nodes? We saw that in patients that did not receive neoadjuvant chemoradiation, in those cases in which we found more lymph nodes when we used the alcohol immersion technique, really, although we had more lymph nodes, you can see 27.6 was the mean compared to 9.6 when we used the traditional method, really the number of positive nodes did not change. So yeah, we had more lymph nodes, but we didn't find any difference in the staging. So I don't know if it was important or not. However, when we looked at the chemoradiation group, again, we found more lymph nodes using the alcohol immersion technique, but also we did find more positive nodes. So when we used these techniques, we were able to find an upstaging in those patients. So we always do this now because in our experience, the use of techniques that increase the number of nodes may end up in upstaging the patient. This has been proved by other authors where they found, this is a group also from Korea, in which they found that those patients that have less than 7 lymph nodes retrieved have a decreased overall survivor and an increased local recurrence. You can see some of these lymph nodes, when you dissect them, are very easy to see. You see the size, but some of them are really tiny. So if you're not paying attention, you may miss them. Same, once we put them in the cassettes, these are positive nodes, you can see, easy to see. Some of these are really tiny and you may not see them unless you use techniques that enhance visualization. Now, we always need to remember that in the TN system, there's very important factors for rectal cancer that are not included. Circumferential margin of resection, that is a very strong predictor of survival. The problem is, again, that you need to educate your pathologist that you always want the circumferential margin of resection reported. The reporting of this is very inconsistent, and it varies according to the place that you are. For example, Norway at the beginning, look at the amount of cases that they collected. It's amazing, more than 6,000 cases, but in only 66% they had the CRM reported. Instead, in other studies like this collaborative study in Europe, because they educated the pathologists before the trial started, they were able to have the pathologist report the CRM in every single case. So it's possible to train the pathologist, believe it or not. The causes of involved CRM are pretty much 3. Bad tumor, bad surgeon, and bad pathology. It's very easy. Because again, if your pathologist doesn't know that they need to ink the circumferential margin of resection, they have to take the sections where the tumor is the closest, then you're not going to have an accurate measurement. You can see the case that I was showing you before, how the tumor here is going all the way to the circumferential margin of resection, and this has nothing to do with the surgery. This tumor is an aggressive tumor. Here you have a positive node that is also very close to the margin. Also, another thing that is not included in the TN staging system is the quality of the mesorectum. That is probably the most important factor to predict survival in patients with rectal cancer, with or without neoadjuvant chemoradiation. And similar to the CRM, this is even worse. Pathologists reporting mesorectal integrity is very difficult. Most of the reports that I receive from other places, we don't see the reporting of the mesorectum. Remember how a nice, shiny, fat mesorectum should look like? Let's also be sure that your pathologists know how to evaluate the specimens of APR, because it's a little different. Remember this wasting here at the anal canal area. The pathologist needs to be looking for the areas of perforation or planes of surgery that tend to be in the muscularis propria. So this is the same. If the patient received neoadjuvant or did not, these are things that have to be assessed by the pathologist. Other factors, even with complete mesorectoms and negative CRMs and very nice surgery, patients still die of rectal cancer. So it is important that the pathologist looks for vascular invasion, for poor differentiation of the tumor, particularly when you see this kind of nest is not even a gland. This is not difficult to assess by the pathologist. We can all say if a tumor is poorly differentiated or not. Now, I think very importantly is we give neoadjuvant chemoradiation to all patients that have advanced rectal cancer, but half of those patients don't respond at all, and we are exposing those patients to toxicity. So it is very important that our efforts, the new research that we're doing, could look at factors that can determine that response preoperatively. So we did a study with our own Yair Eden, trying to find molecular markers that could be used to predict response to neoadjuvant chemoradiation. We collected 152 cases of rectal cancer. We had many more, but we didn't have the preoperative biopsies in many of them. We decided to study markers that are related with the apoptotic cascade and some other ones that are related to, tumor progression, such as COX-2 and vascular endothelial growth factor. And we use the Mandard TRG system. I think that I'm trying to make sense of why we chose these markers. The way that neoadjuvant chemoradiation shrinks the tumor is through the induction of apoptosis. Very, very simple. And this is basically at the DNA level. So there's different types, as you may remember, of pathways that induce apoptosis. On one hand, we have the intrinsic pathway that is not touched by radiation. So it doesn't matter if you have any problems here in the intrinsic pathway, it doesn't matter at all. The one that you want to be sure that is functioning is the extrinsic pathway, the one that involves the mitochondrial elements. So that's why we decided to study all of these markers that are involved with the extrinsic pathway, P53, 21, and 27, and APAF1, that is a marker that is present in the mitochondria, again along with BAX and BCL2. For the progression markers, we chose the vascular endothelial growth factor because this factor, stimulating the production of blood vessels, provides oxygen and nutrients to the tumor so the tumor can grow better, and at the same time increases permeability. Why is this important for radiation? Because that edematous interstitium that produces makes radiation and chemotherapy very difficult to get inside the cell. And I'll tell you also why we chose this marker in a second. COX-2, part of the arachidonic acid metabolism. Remember, COX-1 present in all the cells, COX-2 only present induced by certain factors such as oncogenes, carcinogens, etc. COX-2, as you remember, it's going to act in the prostaglandin metabolism, and particularly COX-2 through prostaglandin E2 promotes the angiogenesis, tumor growth, inhibits apoptosis, and also decreases the level of immune surveillance. So that's why we also decided to use this marker. Also, I think you may all know that we do have antibodies against the vascular endothelial growth factor and COX-2, the anti-COX-2. So these are two critical molecules because if we can show that they are upregulated in those pre-biopsies, pre-neoadjuvant radiation biopsies, we may in the future want to give these antibodies to the patient before we start neoadjuvant chemoradiation. So to summarize the results, for most of the apoptotic markers, we did not see any difference in the tumors that responded and did not respond. So this was kind of useless in a way. Now, the only apoptotic marker that was strongly correlated with tumor response was that APAF1 marker. So the tumors that have upregulated APAF were the ones that responded the best. Okay, the reason that probably APAF is so important is because it's one of the last target of apoptosis. So the malignant cell cannot look for other routes to fight the oncogenesis. This is one of the last steps. And we saw that the upregulation of COX-2 and vascular endothelial growth factor was also related to less response. So upregulation of APAF1, better response, upregulation of the vascular endothelial growth factor and COX-2, less response. And the possibility of using immunological agents before neoadjuvant chemoradiation in these patients, this may be something important. So to conclude this business of evaluating specimens of neoadjuvant chemoradiation by your pathologist, you should be able to get pathology reports that, of course, have the TN staging system. I'm sure that everybody here receives reports with TN. Now, the consistency in reporting the mesorectal quality, the plane of surgery, I'm sure, is not that consistent. Same situation with the CRM, and the same with the tumor regression. I think it is very fair that you go to your pathologist and you demand that you want a pathology report that includes all of these parameters so you can plan the treatment of the patient better. Thank you very much.